at the onset, I thank the organizers for giving this opportunity. It's a very big topic. I think it's already covered in afternoon. I'll just rush through it so as to finish early. So first of all, early lung cancer used to be only surgery. Then why chemotherapy was required? And if then we had given chemotherapy, why much more than chemotherapy was required? These are the questions we'll try to answer. So initially, depending upon the stage, we can see that the 5-year survival dipped down to almost like 1/3 patients used to die at 5 years, and one in 4 patients used to survive till 5 years. So this was a very dismal outcome with surgery only. Then everybody tried to improve the outcomes using adjuvant chemotherapy, and individual trials could not answer the question. Then the patient level data were pulled from the 5 trials, and what it showed was roughly around 5% of overall survival benefit was there. This was a latest meta-analysis we had talked this about in afternoon, and it shows that almost dismal, like 5.4% benefit despite using 4 cycles of doublet cisplatin based chemotherapy. And you can see that in stage 1A, it is actually detrimental, hazard ratio was 1.41, stage 1B not very good, 0.92, stage 2-3 there was some benefit, but not that great, 0.83 hazard ratio. And despite chemotherapy, almost 61% patient used to die in stage 3 at the end of 5 years, and in stage 1B 33% patient used to succumb. So this is the area which had unmet need, and we wanted to improve this, and hence we what we did, we took 2 approaches, adding immunotherapy or using targeted therapy. So I'll just go first with immunotherapy approach. The patients who are excluded from these trials are generally EGFR driven tumor. These patients are excluded from this trial, and as afternoon this slide was presented already, that lot of trials are being done in adjuvant, neoadjuvant setting and only adjuvant setting, and these are the 5 trials which have some positive outcome, and I'll just go through them. So this is the graph showing that the maximum recurrences in stage 3 generally occur in first 2 years, and this is the most time where we should prevent our recurrences. And we know that there are advantages of using neoadjuvant immunotherapy, that there is more robust on durable anti-tumor response. We can prevent immune tolerance and escape mechanisms, and combining immunotherapy, the drug, and chemotherapy might further improve the outcomes in these patients. Adjuvant, these generally have better safety profile as compared to neoadjuvant, and they might be able to restore anti-tumor immune activity. So so first coming to the Asian trial, it was a phase 3 global randomized double-blind control trial. Here, neoadjuvant durvalumab was combined with platinum-based chemotherapy, which was compared with just being platinum chemo-based therapy with placebo, and then surgery was done and followed by durvalumab maintenance versus no maintenance. And the primary outcome, what they measured was EFS and pathological CR. And here we can see that EFS at 2 years was 63.3 versus 52.4, and the hazard ratio was 0.68. And you can see that almost in subset, all the subsets, whether PDL1 is less than 1 or 1 to 49 or more than 50, it showed improvement. But as the PDL1 increases, the magnitude of benefit increases. And in histology, both histologies, it was useful. And pathological CR rate increased from 4.3 to 17.2%, and the major pathological rate also improved from 12.3 to 33.3. And this is so this was for durvalumab. Now coming to the second drug, that is pembrolizumab, Keynote 671. Here same they had used neoadjuvant pembrolizumab plus Gemcis or Pemcis followed by surgery versus chemotherapy, that is Gemcis or Pemcis followed by surgery, and in the immunotherapy arm, pembrolizumab maintenance was given. And here we can see that the EFS and OS both had improved. EFS at 24 months was 62.4 versus 40.6 months, and in Keynote, OS at 2 years was not that significant, but you can see at the tail the curves are starting to separate. And the pathological CR also improved from 11 to 30, the major pathological response, and complete pathological from 4 to 18%. The next trial was nivolumab, neoadjuvant. was given 3 cycles plus chemotherapy. Here PAT-CR increased from 2.2 to 24%, and major pathological response increased from 9 to 37%, and we can see the EFS rates. So this is the 4th trial where adjuvant atezolizumab was used, and it showed DFS benefit, and it got FDA approval for same. And this is the adjuvant pembrolizumab post chemotherapy. Here also the DFS improved. The main question is whether this improvement in pathological CR rates or PFS will it increase to OS. So we have example of Pacific trial where durvalumab increased the PFS and ultimately it improved the OS. So we are hopeful that it might improve the OS. So it has translated that American Association of Thoracic Surgery now recommends using neoadjuvant or adjuvant immuno-oncological drugs in non-tumor driven, non-mutant tumors. And in the NCCN guidelines also have updated and recommended these drugs. And coming to the second part, EGFR sensitizing mutation in SLCs. So we know that in Asian and Indian population, around 30 to 50% patients have EGFR mutation, irrespective of the stage. And the first generation TKIs, there was DFS benefit, but there was no OS benefit. So Adura trial was designed to using a third generation TKI to see whether there is OS benefit. And we all know the curves that in stage 2 and 3A, there is an absolute benefit of 12% at 5 years. And if we include the 1B stage also, it still maintains 10% 5 years OS benefit. These are the OS curves by stage. And it is beneficial even in late 8-5R substitution or exon 19 deletion with or without adjuvant chemotherapy. The subset analysis benefit is still maintained, and it has been incorporated in the latest guidelines. So key takeaways include early lung cancer. This space is evolving. We might get further new drugs next year, and it's an exciting area to keep watch on. Thank you.